Today also we are now distributing the mementos on the stage due to the sudden demise of ex-CM. So all the speakers and the chairpersons can collect the mementos from the registration desk. Now we can start our next session, session 8, R.L. Manchanda Best Paper Award.
So you have 8 minutes and I think 6 plus
7 plus 1.
7 plus 1. Okay.
Good morning everyone present here. I'll be talking about my topic which is Doctor, is my keloid cancer? So many of you will be having a query that why such a question, like the paper is on a question based theme. So I'll be discussing about that also. Keloids basically result from abnormal wound healing which is in response to the skin trauma or inflammation. Despite their common occurrence, keloids, they remain one of the most challenging dermatological conditions which is not that much successfully treated as expected by the patients. There are multiple treatment modalities which are existing, although none of them are successfully uniform in their achieving the targets. The most common treatment include the intralesional or the topical steroids, which is triamcinolone, cryotherapy, radiotherapy, laser therapy, which is the trending and the new treatment modality these days, and also biological anti-proliferative drugs, which I will be talking about in my paper presentation. These are usually, the refractory ones are usually followed by surgical excision, and the probability of the recurrence of keloids after the surgical removal is high, which can sometimes exceed more than 50% also. Thus, the treatment of keloids is a big challenge because of the poor response rate and high risk of recurrence after the treatment. Bleomycin, which I have used in my study, it is a glycopeptide antibiotic which is widely used as anti-cancer agent due to its anti-tumor or anti-proliferative activity. It is rapidly eliminated primarily by the renal excretion. Half-life is usually 2 to 4 hours, and resistance to bleomycin in normal tissues of the body can be correlated with the presence of a bleomycin hydrolase enzyme which inhibits its binding and cytotoxic activity. The low concentration of the enzyme in skin and lungs explain the unique sensitivity of this tissue to bleomycin toxicity. Thus, the drug is used in treatment of Hodgkin's lymphoma, squamous cell carcinoma, testicular cancers, as well as in the treatment of the plantar warts. Bleomycin has been used and tried intralesionally to treat keloids as well as hypertrophic scars. This study was conducted on 20 patients diagnosed with keloids of varying sizes, less than 10 centimeter in the largest dimension and durations. These were recurrent and refractory to the conventional treatment, that is after failed treatment for 3 months at least. And these presented, and we were applying our exclusion and inclusion criteria in the department. All the patients presented in OPD and they were diagnosed with keloids of less than 10 centimeter size. They were included, and patients above age of 18 years were taken for the study. The exclusion criteria was large lesions more than 10 centimeters size, pregnant and lactating women, and a known case of CKD or CLD patients, and also the patients who lost to follow-up. This was the methodology flowchart which was applied, and then the patients were included in the study. After inclusion, complete history was documented. Patients were thoroughly explained about the pharmacology, the drug response, the possible side effects of bleomycin, and informed consent was taken in their vernacular language to undergo this procedure. They received intralesional injection bleomycin in 3 sessions on day 0, day 14 and 1 month. The cosmetic scar assessment of the wound healing and the complications were done on post-operative day 7, 14th, 1 month and 2 months. And after follow-up after 2 months, we were assessing them for the need for surgical intervention if required, and if required, whether it was in the form of primary closure, skin grafting or anything. This was the VSS which was used for the study. This had 4 attributes, which was pigmentation, vascularity, pliability and scar height. And according to the attributes, pigmentation was divided into normal, hypo, mixed or hyper, and scoring was done. Vascularity was normal, pink, red, purple, and pliability was normal, supple, yielding, firm, banding and contracture. and the scoring was from 0 to 5 according to that. And scar height for the normal one was 0, which was flat, and then 0 to 1 mm, 1 to 2, 2 to 4, and more than 4 mm. The patients were administered the injection on day 0, 14, and 1 month, and then the cosmetic scar assessment along with the wound healing complications, tissue reactivity, dehiscence, and recurrence was done. The dosage of drug administered was injection bleomycin, 1.5 international units per ml. The usual vials which we are getting was 15 units, so that was diluted accordingly. And then 0.5 to 1 ml per centimeter square was administered, and the maximum dosage per session was 4 ml. This is a first case, young female having a keloid at the sternal region. And then after installation, the second case, post burns, patient was having a sternal region keloid on the pre-procedure day, and after 1 month follow, the vascularity improved, and also the patient got relief from itchiness as well as the pain from the keloid. And this is a multiple keloid, large size, and this is the pre-procedure. And on the same day of excision, we administered bleomycin in this patient, and she went excision and STST on the same sitting. And this is the 1 month follow-up. This is the fourth case, large ear keloid, young female, and bleomycin was given for 2 sessions, and on the third session, the same day we did excision and primary closure of the keloid. This is the post-CABG scar, sternal keloid, large one, and after administration of the bleomycin, patient had significant response from the itchiness which he was having previously. And at day 15, vascularity as well as the stiffness of the keloid decreased significantly in this patient. This is the neck keloid post burns. This is the seventh case, young male, right ear keloid. He went excision as well as administration, and post excision there was a minimal, or we can say it was a very acceptable scar for the patient. The result says 80.8% patients got itchiness relief, and 73% patient got pain relief. The blood vessel status improved in 70% patient, and also the scar stiffness was significantly reduced in the patient, and thickness also improved in this patient. These are the stats that I am having. According to the height, 70% scars they became completely flat, but it was subjected to the bias that they were in the smaller size group. And 8.3 had fairly flat, followed by 17% comparatively and 3% averagely flat scars. This was the distribution of the data, that 8 males and 12 female patients were included. This was the age-wise distribution of the sample population. During this study, it was found that bleomycin improved the vascular condition and mean PSS of the stiffness decreased, and hence we can conclude that it is a safe and effective method for treating keloid. But since we applied it to the refractory cases, we can say that it is better for refractory cases only. And however, still there is a high rate of recurrence after the treatment, that it makes a difficulty in correct management of the keloid scars. And we can use intralesional bleomycin in significant improvement of symptomatic relief for the patients from itchiness, pain, and also the decrease in size of scar can be observed in the patient. These were the references for the study. Thank you.
Thank you, Dr. Burarka. The judges allowed you extra time, around 1 minute, that's fine. We need to listen to the study. So I wanted to understand how did you distinguish between the keloids and the hypertrophic scars? Did you isolate them in the beginning, or what did you?
No, sir. I took both the cases in my study.
So were the results analyzed separately or as a together?
No, it's a combined.
Combined.
Yes.
Any other?
Good morning, everybody. Today I am presenting on the management of the neglected post-burn knee flexion contracture usually using Elizardo frame. A flexion contracture of the knee is a condition in which the knee is in fixed bent position and unable to achieve full extension. The etiology is multifactorial related to the trauma, burn injuries, cerebral palsy, polio, and advanced osteoarthritis. We conducted a study among the patients of post-burn knee contractures. The burn contractures produce restriction in motion and unacceptable aesthetic results, frequently with persistent wounds. The post-burn flexion contracture of knee making up to 22% of the large joint contractures. This study was carried out to assess the result of gradual correction of the post-burn flexion contracture of the knee joint using the ring fixator system. 18 patients with post-burn knee contractures were studied and operated by us using ring fixator system achieving gradual distraction. The study was approved by the local ethical committee. Among them, 10 were adult males, 7 were adult females, 1 was adolescent female. They were of around 1 to 3 year duration of post-burn status. All patients suffered deep partial and full thickness burns of lower limb from 11 to 25% of the total body surface area, resulting in the flexion contracture of the knee. All patient belongs to grade 3 flexion contracture. After evaluation, procedure was performed. This is the picture of the patient having severe contracture of the hamstrings, calf muscles, vascular elements, popliteal nerve shortening, and there is a subluxation of the knee joint. The procedure involves release of the hamstrings and the constricted fibrotic bands, followed by construction of the ring frame with distractors. The frame consisted of femoral block and tibial block connected together using uniplanar posterior hinges, one medial and lateral. The posterior distraction mechanism was used to gradually correct the deformity. Distraction was started as soon as the postoperative pain subsided at an average of 2 full turns per day, produce a distraction of 1 mm per day at the posterior aspect of the knee joint. After every 3 weeks of distraction, resting period of 10 days were given to prevent overstretching of the neurovascular bundle. The duration of the correction ranged from 6 to 10 weeks. All patients were kept in the frame for 4 weeks, achieving full correction. The frames were removed and the above knee plaster cast was applied for 4 weeks. A brace was used to guard against the recurrence for the 3 months following the removal of cast. Desirable correction to almost full extent was achieved in all the patients. Post removal of the ring fixator, achieved correction was maintained in the above knee cast for 4 to 6 weeks. The follow-up period ranged from 12 to 30 months following the removal of the brace. One patient developed ipsilateral equinus deformity along the sensory disturbances over the dorsum of the foot following the procedure. The sensory function was fully improved with the conservative management, but while operative intervention was performed to correct the equinus deformity. Immediately after the frame removal, all had the problem of knee stiffness, which gradually improved with the rehabilitation. 14 patients had no recurrence of deformity after a year follow-up, whereas 4 patients had a partial recurrence of the deformity of around 15-degree flexion contracture. All patients were able to walk without any walking aids. Patients who developed a recurrent flexion deformity of 15 degrees were given a high yield for compensation. None of the patients included in the study had fractures during frame application or during period of follow-up. In addition, none of them had a vascular injury during frame application or during distraction. This is a frame showing femoral and tibial block connected by the hinge and the connecting rods. Burn injury is still the most common cause of trauma, especially in the low and middle income countries. Burn contractures produce restriction in motion and acceptable aesthetic result. Post-burn flexion contracture presents as a cosmetic defects affecting the lifestyle of the patient, needs a surgical intervention. Patients with severe deformity may not be treated by the routine flaps grafting, but due to the involvement of the joint, subluxation of joint, shortening of the intra-articular cruciate ligaments, articular ligaments and the capsule. Extensive burn results in the formation of severe contractures. Patients with burn scar contracture interferes with the daily activities of the life and difficulties in receiving education and securing work. There are 2 types of flexion contractures of the knee, one associated with the joint restriction and fibrous ankylosis, and other with joint anatomy and the mobility are preserved. The type 1 are difficult to manage. Flexion contracture of the knee is a cause of crouch gait pattern, and there are difficulties in standing, sitting, and daily activities. It may also cause degeneration of the patellofemoral joint and stress fracture of the patella. Severe knee flexion contractures greater than 80 degrees are rare and difficult to manage. Such patients frequently have a cutaneous and vascular complication. Current method of managing contractures are soft tissue release, external fixator and rail fixator. We presented a study consisting of gradual correction of the deformity through distal hamstring release and the application of the fixator when the extension is limited by the posterior soft tissue. Several advantages offered by the external fixator are progressive correction with the simultaneously correction of the associated foot deformities, limb length discrepancy and neurovascular shortening. Acute correction of the contracture may lead to serious complication. In contrast, gradual correction of the knee contracture avoid acute stress injury to the soft tissue and prevent compression of the anterior joint. Further, gradual correction of the stenosis lead to soft tissue lengthening, which makes the contracture less likely to recur. Our technique achieved full correction of the flexion deformity in all the cases, despite the fact that all knees showed the marked destruction and the intra-articular adhesion from before frame application. One patient developed equinus deformity, which was treated by surgical intervention. Patients who developed partial recurrence are managed by the shoe modification. None of the patients had a vascular or any fractures during the dissection. Through this study, we found that in post-burn knee flexion contractures, procedure of the distal hamstring release correction with the ring fixator gave the best results, as almost all the patients achieved bipedal stable gait without support and able to perform their daily activities. However, the recurrence after the frame removal remains a problem, which can be prevented by this strong compliance of the patients with braces and regular follow-up. We strongly suggest this technique, as it greatly helps in reducing the morbidity of the postbone contracture.
Thank you. Any questions regarding the procedure followed or the study selection criteria?
After the complete dissection, did you use skin grafting or not?
Sir, we did skin grafting in most of the patients.
When you started the destruction,
Sorry?
on which day you started destruction?
Sir, when the patient, we did in the first stage only, no?
You can speak in the mic so that everybody can listen.
सर जब पेशेंट ओटी में लेते हैं तो स्टार्टिंग से डिस्ट्रैक्शन स्टार्ट करते हैं थोड़ा विद अलोंग विद द सॉफ्ट टिश्यू रिलीज एंड द हैमस्ट्रिंग रिलीज एंड फाइब्रोटिक रिलीज ऑन द फर्स्ट डे ऑफ सर्जरी.
ग्राफ कब लगाते हैं?
ग्राफ सर लास्ट में जब
खत्म हो जाता है.
Thank you. Thank you. Just to reiterate the previous instructions, if your slide contains the institution name. Yeah. Fine. Everybody please check again as the current and it is presented. Remove reference to the institution or name of the guides.
Good morning everyone. My topic for today is autologous fat grafting for scar modulation. Autologous fat grafting is a surgical procedure that involves transferring a patient's own fat to improve tissue quality, augment volume or fill the defect. Clinical application including treatment of scar, ulcer, burn or breast augmentation, facial rejuvenation or rhinoplasty. As we know, scarring is a natural wound healing process, and current scar treatment like corticosteroid, cryotherapy, radiotherapy or silicone dressing and pressure garment have limited scientific evidence on efficacy and its own side effects and complications. Laser therapy on surgery is also available. Laser therapy although improves scar appearance but has high recurrence rate or complication like skin discoloration. And surgical options like skin grafting, excision or dermabrasion have high complication rates. So we require more safer and regenerative options. Autologous fat grafting is a new option for treating scar, first described by Newberg in 1893 and later refined by Coleman. The regenerative features of fat, probably due to adipose tissue derived stem cells, make fat grafting useful for more than just volume replacement. Its benefit is biocompatibility, low cost, regenerative properties, and it improves skin texture and has positive effect on hyperpigmentation or scar quality. And there are three types of fat grafting based on particle size and purpose: macrofat, microfat, and nanofat. Macrofat has larger particle size and used in areas requiring pronounced lift like cheek or breast, and it gives impactful result with a natural appearance. And microfat uses sculpting specific area and gives natural looking result. And nanofat is used under eye or in fine lines and gives subtle and precise improvement. Nanofat grafting term introduced by Tonard et al. In 2013, and its preparation process is after liposuction, fat emulsification by suffering between syringes, approx 13 times. It removes adipocytes while retaining stromal vascular factor and adipocyte-derived stem cells. Its mechanism of action based on adipocyte-derived stem cells and stromal-rich vascular factor. It promotes scar remodeling and elasticity, and it contains growth factor, which aiding in collagen deposition and fibrotic response reduction. And it has regeneration properties also that enhance dermal and subcutaneous tissue. Key findings from multiple studies are adipocytes not viable post emulsification, so we avoid emulsification process. And adipocyte derived stem cell count comparable to the standard lipoaspirate, and mechanical process does not alter stromal vascular factor or tissue viability. And nanofat simplifies injection process and maintain regenerative properties. Studies also include advantage of nanofat therapy. It stimulates scar tissue regeneration, improves scar pliability and elasticity, and it reduces fibrosis and inflammation. And it is long-lasting and minimal invasive treatment option. Technique for fat grafting. Fat grafting done through Coleman technique. First, tumescent anesthesia using clean solution was done, and subsequently fat tissue was obtained using a liposuction cannula connected to 10 ml fluid lock syringe. Suction was achieved by steady negative pressure. Then centrifugation, electric centrifugation for 3 minutes, but we avoid this centrifugation process. After that, mechanical emulsification was done, used by nanotransfer kit with fluid loop connector. Then the filtering process, in which we pass through nanotransfer device with dual layer filter, and it produces purified nanofat. Alternative nanofat preparation techniques are after fat liquefaction, filtered through sterile nylon cloth and using 6-layer gauze piece, and we collected nanofats. Its purpose is removal of connective tissue remnant to prevent needle blockage. Then we inject the fat with the help of 1 or 2 ml insulin syringe for superficial intradermal injection or 21 gauge cannula for subdermal injection. We inject it until yellowish skin discoloration appears. Outcome assessment based on OPD basis, and each patient will be asked if she or he is satisfied with the result or not. Post-operative photograph will be taken at 1 week, 3 months or 6 months. Scar assessment scale used patient and observer scar assessment scale, which use patient and observer also. We ask about thickness, itching, pain, stiffness, irregularity, and each factor will be scored from 1 to 10, and total score will be calculated. We have to compare the pre-op or post-op score. This is the performa we give to patient to fill. And complication of the process like edema, pain, fat embolism, infection, discoloration, fat necrosis, oil cyst formation, calcification, skin necrosis, or bruising and contour irregularity at the donor site. These are the photos of pre-op and post-op at 3 months. This is post-burn scar. In this we give macrofat or nanofat also. These are hemifacial hypertrophies. Our experience till date, for now, nanofat grafting was performed for 17 patients, and clinical results gradually improve over time, but maximum for 4 to 6 months post-operatively. There were no important complications seen in this series, only temporary edema. Face is the most common site for grafting, and thigh was the most chosen site for harvesting. Regarding the POSAs, before and after treatment, there was a significant difference was created in pliability, vascularity, and stiffness of the skin. Complaint of pain and itching also decreased, although 4 patients were not satisfied with the result and opted for another options. To conclude our study, autologous nanofat grafting shows potential in scar modulation, benefit like improved scar quality, patient satisfaction, and the challenges are variable success rate and need for standardized methods. Thank you, sir.
Thank you, Dr. Akshay. There are 2 questions. First is what is the technique of preparation of nanofat you followed one, and second, who clicked the photographs? Were they sent by the patients themselves or you clicked them?
So, 1 to 2 photographs sent by patients.
Or the technique of nanofat? Could you elaborate? What did you do?
Sir, after 2 minutes anesthesia, liposuction was aspirated and
2 points I want to understand. You said we avoid using centrifuge.
yes, sir.
Why is that?
Sir, because adipocyte stromal cell, some studies show adipocyte after centrifugation.
What is the RPM you use and what is the time duration you use usually?
No, sir, we don't use.
So you don't use at all, but you
Yes.
showed it. No? Doesn't matter. So how did you prepare nanofat? You aspirate it, then
Aspirated, then we after.
do you use you showed I think IV connector? for
Yes, sir.
fluids.
Yes, sir.
So
3
do you use that?
3-way camera, yes.
So-
For emulsification.
So how does that help in emulsification?
Sir,
Because
more.
that the gauge will be more than 18 gauge in that.
Yes.
So how does that affect in emulsification?
We have to pass 30 to 50 passes. Then emulsification was done, and then we purified it with the help of nylon sheet or gauze piece, 6 layer of gauze piece.
You think that it was emulsified or it is emulsified?
So multiple studies uses this method.
Okay. Any other questions?
My topic for paper presentation is analysis of locoregional and free flaps in foot and ankle reconstruction. Introduction. Foot and ankle region is vital area of lower limb for perfect ambulation. Soft tissue defects are commonly seen as a result of trauma, infection, tumor, diabetes, and vascular disorders. Coverage of this region is very essential as underlying neurovascular bundle, tendons, bone, and joints are easily exposed. However, the safe coverage and reconstruction needs a well-padded well-padded tissue because these vital structures are hardly covered by any soft tissue other than a thin skin cover. Reconstruction of foot and ankle area defects is a surgical challenge for reconstructive surgeon, especially difficult to heal wounds and large wounds, which may necessitate bringing a remote tissue for cover due to lack or scarcity of local tissue. Aims and objectives. The aims and objectives of the study is to analyze the indications for locoregional and free flaps in foot and ankle reconstruction, mean operative time of various flaps, immediate post-op complications of various flaps, re-exploration on re-operation rate, and static and functional outcome of various flaps, and secondary procedure, if any, done. All the patients who came to our OPD or emergency with the foot and ankle defects, irrespective of the cause, maybe due to trauma, diabetes, tumor, or infection, were enrolled in the study. A total of 68 patients were operated, which includes 23 patients with locoregional and 45 free flaps. Results of these studies as follows. Average years for the patient is 23 years for free flaps and 40 years for locoregional flaps. Most of the patients were male in both the groups. Road traffic accidents was the most common cause of and mean size of defect is 80 cm square in free flaps and 27 cm square for locoregional flaps. Average free flap dimensions were 111 cm square and 73 cm square for locoregional flaps. The average duration of surgery in locoregional flaps was 3 hours and 6 hours for free flaps. Complications include one locoregional flap and one free flap completely failed, and distal margin necrosis were found in three patients in locoregional flaps, and one locoregional flap got infected. The average duration of hospital stay was almost similar in both the flap types. Secondary procedure, out of total patients, 68 patients, 12 free flap patients and 7 locoregional flaps required secondary procedures, and 1 free flap shows donor site morbidity. That is infection, and we have to regraft that area, donor site area. There are some patients. This is a patient came to us with a diabetic foot ulcer over posterior aspect of heel, anterior heel. After thorough debridement and VAC therapy, when granulation tissue has come, this defect was covered with reverse sural artery flap, and last picture showing after detachment and final inserting of this reverse sural artery flap, well settled flap over anterior heel. Second case, this is a 5-year-old female child presented to us with compound defect post RTA, compound defect dorsomedial aspect of foot. This was covered with a free gracilis flap harvested from same thigh, and this is the post-op, 2-month post-op of this patient. Another patient, 60-year-old male, presented to us with compound defect dorsum of foot, and this dorsum of with multiple fractures, tarsal fractures covered. K-bar fixations were done for this, and defect was covered with free gracilis flap harvested from same thigh, and this is all the post-opics. Another 6-year-old male child presented to us with compound defect post RTA, dorsolateral aspect of the foot. Free ALT flap was done for this patient, and it's a patient, 4-year-old female child presented to us with the degloving injury over foot post RTA. This after thorough debridement, defect was covered with free latissimus dorsi flap, and flap was further covered with split thickness skin graft, and this is 2-month post-op, 1 month post-op of this patient. Conclusion: because of limited soft tissue and local flap availability, local flap is restricted to small defects, and locoregional flaps shows more complication rates as comparison to free flaps. Free flaps are found best in large defect and areas where nearby soft tissue source is not available. The duration of surgery in free flap is more due to complexity of the procedure. Thank you.
Thank you for finishing in time. So what is your recommendation after this study?
Sir, for small defects we can we can cover the defects like post. So for large defects we can use free flaps, and for small defects we can do locodehedral flaps.
So what is the new thing which the audience has learned out of this study? Or we have reiterated the previous concepts?
Sorry, sir.
Doesn't matter.
One of the cases of the sural flap which you showed that reached quite far on the plantar aspect, and I think it was raised right up to the popliteal fossa region.
Sir, we have delayed. First, we delayed.
That's what I wanted to say.
Yes, sir.
You can raise up to that level only if you have done that delay.
Sir,
and I
delay.
think one of your pictures was showing that delay was done.
Ji, sir.
Thank you. So the next presenter is Richam Kashyap. And he is speaking on.
My presentation for today will be wide awake local anesthesia with no tourniquet, the acronym VALENT, technique in hand surgery. So VALENT is an anesthetic technique that is used by surgeons to achieve a pain control in the operative site through a local injection, bypassing general anesthesia. And this was proposed by Dr. Donald Lalonde in 2005. So since the introduction, VALENT has continued to gain popularity among surgeons and with a high patient satisfaction and clinical outcomes. Coming to the constituent of the VALENT solution, so here we take local anesthetic 1% with epinephrine, that is 1 in 1 lakh concentration, which is mixed with 7.5% of sodium bicarbonate, and that is given at the rate of 1 ml per 10 ml of local anesthetic. And this is sodium bicarbonate actually acts as a buffer for the acidic pH of lidocaine. And so if it depends on how much of the solution is a requirement. So if we require if we require 50 to 100 ml, so accordingly we will take 0.5% of lidocaine with 1 in 2 lakh epinephrine. And if we require more, that is 100 to 200 ml, in that case we will use 0.25% lidocaine with epinephrine in 1:4 lakh concentration. So this amount is based on where we are doing the surgery in the hand. So when we take extremities perhaps, or till the wrist, in that case we use around 50 ml or 50 to 100 ml. But as we go further proximity, more of the solution is required. So this diagram basically showing in case of hand especially how much of volume of solution is given on the dorsal and volar aspects of the hand for various surgeries. So let's say for example we have trigger finger, so in that case we would give around 4 ml, 2 ml on the proximal of each of the phalanges and 1 ml distally. And likewise if we have to treat carpal tunnel syndrome, so in that case we will give around 30 to 40 ml, 10 ml on the proximal aspects of the wrist on each side. So here is a table that shows how much of the solution gives how much of a duration of action. What we are basically using in our study is lidocaine 1% with atidine, so we get 6.86 hours of anesthesia, and that is good enough for the cases that we do. So coming to tips to minimize the pain. So here we have got a buffer that is being used, that is 7.5% bicarbonate. We can use 27 gauge needle, that is what we are using. We try to insert the needle perpendicular to the skin for less pain, and do not inject intradermally, it hurts more, so we have to go subcutaneous, and injection of 0.5 ml into the fat under the skin is done. And then we pause until the patient tells you that the stain is gone. And we slowly inject so that we have 5 to 10 ml in the hand or forearm before moving the needle forward into an area where we do not have, where we have to yet give anesthesia. So this is, and then after that we inject into the most proximal areas that are likely to be dissected, and we wait for 15 to 20 minutes before injecting distally, so that the distal nerves have a time to be blocked, and always at least 10 millimeters of anesthesia have to be locally ahead of the needle, so that the needle can be advanced only into the numb areas. And we use more local anesthesia than is expected in hand and forearm. So these are the certain conditions, mostly where we use Valent, though it can be used in many other conditions, but most commonly we are using for carpal tunnel release, collateral ligament tears of the MCP joint, depressed contracture, flexure, tendon repairs, fracture fixations, PIP fusions, and trigger finger. So coming to the benefits, the local anesthesia is more convenient than general anesthesia in elderly patients with medical conditions. So it avoids the risk associated with general anesthesia. And by utilizing local anesthesia, we are avoiding tourniquet, which is cumbersome to the patient. So it enhances their comfort level. And most importantly, from a surgeon's perspective, during the procedures, the flexor tendons can be analyzed, and in real time they can be assessed as to their motion of range of motion of the fingers, and this helps us to rectify any mistake or anything that we have done intraoperatively. So we did this. We have done this Valent technique we have introduced in our hospital, and we want to see the merits and demerits. These are the inclusion and exclusion criteria. So children were not included. And what we did find was that out of around 200 patients, so there was 92% patients were pain-free during the surgery. These were the number of pricks overall that were felt during the surgery. 2%, 2 or a maximum of 8, 6 pricks were felt. Anxiety levels can be seen in around 200 they were not anxious. Overall experience was the patient was good. And they wanted to recommend Valent to others or for future procedures. So here, as we can see, this is a patient who was having depressed contracture. We have given Valent injection we are giving, and so once this is done, the contraction band is removed, and while the patient is on the operation table, we are able to assess our how we have progressed, and this is the final picture when once this is done. So the patient goes back without any general anesthesia, and he is much more happy. Thank you.
Yeah, so any questions from the audience? So thank you so much.
Thank you, Dr. Raju. May I invite the next speaker, Dr. Uday, for his presentation, a prospective study to assess the role of AI in thermal burn management.
Thermal burn management. The effective progression of the burn injury hinges on the initiation of the appropriate initial treatment. Appropriate treatment will lead to a shorter hospital stay, reduced expenses, and lower risk of hospital-acquired complications.
So to gain success of overall treatment, precise assessments of the total body surface area and the wound depths are needed. Using machine learning and AI, it is possible to pair the clinical images of the burns and train algorithms to rapidly and accurately predict the percentage of the burn area as well as the depth. And ultimately, it will be useful to enhance the efficiency and precision of the diagnosis and treatment planning in the peripheral center. It is a prospective observational study done between July 2022 to December 23, and it is done in a tertiary center with collaboration from the Department of the Computer Science and Engineering, Indian Institute of Technology. Our inclusion criteria were children group were taken until the age of 10 years and adult group from 11 to 65 years. And patients presenting to the emergency with thermal burns were included in the study. And more than 65 years adults were excluded from the study. Thermal burns of more than 60% were excluded from the study. And patients presented with thermal burns requiring additional resuscitation protocols were excluded from the study, and patients with negative consent also excluded from the study. Our aims were to assess the accuracy and reliability of the AI in burn surface estimation, depth estimation, as well as fluid and caloric requirement estimation. We had 4 steps in our study procedure. Initial step was clinical assessment. We take the patients presenting to trauma outpatient department with thermal burn injury, and we will include the patients according to the inclusion as well as the exclusion criteria. And after that, we have also taken the demographic data as well as noted all the clinical details which were related to the patient. In step 2, we acquired the data from the patients using clinical photographs. We used Canon M50 Mark II DSLR camera, and then pictures were taken either the patient with a background, either the patient was standing or in lying position. And these were the sample images which we had taken, and some images were also acquired during the machine learning process by the Indian Institute of Technology, and these were the images. And clinical photographs were manually annotated using the Cephexer software. We have initially gone through various softwares like LabelMe, MATLAB, Lablog, Cephexer, and ultimately we selected Cephexer and we did pixel-wise mapping of the burn regions. And this is an example where this is the original image in the first picture. Second picture is the pixel-wise annotation done in the Cephexer software. So coming to step 3, sample input image. We will give the input image, we will mask the image. Later we will train the model to semantic segmentation. Ultimately we will test another image and to check whether the AI is able to, whether the machine learning is able to predict the burn area or not. And in addition to that, we also classified depth into 3 groups: partial thickness, superficial, deep, and then deep thickness. Coming to validation, a total of 574 images were taken. All these images were annotated and used to train a deep learning model for burn region segmentation. These were our experimental results on segmentation, where we also compared various literatures where they have used different softwares. Ours was denoted in the red, where multi-specific and multi-pathway, where we have achieved an accuracy of 0.9, sensitivity of 0.8 and specificity of 0.9 and positive predictive value of 0.8. These were the experimental results. This was the original image which we have given to the model, and this was the burn region predicted by the model. The same image in a larger picture. And then coming to depth assessment, after training these images, we have taken 70 images for training, and 30% of the images were for testing. Of the 4 softwares which were listed here, ResNet 18 had the most precision of all, while accuracy was also by the ResNet 18. And these were some qualitative results which were given by the deep learning model on ResNet 18. The first picture is having partial thickness superficial with an accuracy of 92.3%. The second picture of 79% and so on. Coming to conclusion, it gave us valuable insights in the development and evaluation of AI model for burn segmentation. which will enhance the clinical decision in burn care. And one more thing, what we learned was there is a need for refining the research and to gather extensive data sets, extensive images to train the AI model for more precision. And then ultimately, the goal is to improve the outcomes in periphery centers where resources are in short supply. And the contribution so far we have achieved is we have developed a protocol for segmentation. We have validated our segmentation model against established models in literature. And we have also done the data annotation, which were done pixel-wise, the semantic segmentation method, data collection and the data cleaning. Limitations and future work. AI actually requires extensive data. Our data was a total of 574 images, which was relatively much lesser than what is actually needed to train an actual AI model. And then our work is to focus on gathering more data sets for image augmentation as well as the fine-tuning process of the model. Thank you.
Thank you, Dr. Vijay, for finishing in time. So again, the same question. What did you learn and what was your aim?
So our aim was initially when we started the study, we thought of seeing whether the model can actually predict, after taking a clinical picture, whether the training model can actually predict the burn surface area.
About your study that you seem to have achieved it, but what is your final aim?
So final aim is to what we have gathered is only machine learning. Sir. Our next stage would be gathering more data set, ultimately developing an application where with a single click we can estimate the depth of the moon and we can estimate the surface area of the moon, which will help in centers where their reach to the tertiary center might take time and to start initial resuscitation protocols which will improve the patient outcome a lot, sir.
Any questions from the audience?
Anything that you are planning or there is a process to deal with the areas such as axilla or wherever folds which you can't capture in any front or like you just said in your summary that you want to develop a model which can assess everything with a single click. This is what I wanted to know, that how can you assess these axilla, groin, these areas with a single click? These areas will always be neglected.
Sir,
or you need to develop special positions for every burn involved area?
We had taken frontal and lateral pictures of all the patients, sir. But what we have done is we have correlated our photographs with the actual London product chart, which is a 2D model at present.
So do you think this thing can help you to develop 3D models for assessing the TBSA and rewrite the TBSA charts which we have been using so far? Was that the part of your study? Was that factored in the study?
We have factored in, sir, initially. Okay. We thought whatever pictures we are taking for TBSA estimation only frontal and lateral pictures.
No, we get it. The body is 3D, all charts are 2D. So you have to develop new models in which the lateral view is included.
Is also included. Yes.
That could be the future plan. Is that?
Yes, sir.
Who is teaching the depth assessment?
So depth assessment, there are multiple ways of assessing depth, sir. There are infrared, there are color. We use the color segmentation.
You use Canon camera.
Yes.
How will it assess the depth?
Sir, we have assessed the depth based on color, like partial thickness will be looking red and the partial thickness deep will be looking white. That way we have color graded the image before training, and then we trained the model based on the color, and then we tested on the rest 30%. After testing, we have evaluated clinically whether it was correlating with the original clinical decision.
Was there a timeline to your photographs? On which days did you take the photograph? When was it fed?
Sir, actually, since depth is dynamic, we thought initially we'll take on day 1 and then day 3. Only 2 days we have worked on the sequential dressings. We took photographs.
Thank you. Questions? Thank you.
Now we call upon Dr. Jatin Ghai, who is going to present